I'm glad to be able to join you. I'm actually here in Ensenada, sitting on the balcony. I
Oh, good morning, Sandra. Not, that's
can't get my camera to work though.
oh well, that's all right. What you just sit there and we're just happy that you're here. I'm just happy that you're here. All right, good morning, everybody. We are we are here today with our seniors real estate networking meetup group, and I'm just saying that because we are recording. It's our last meeting of 2025. We're going to have a great meeting today. Sita Wong is with us today. She is a doctor of physical therapy and a CSA, certified senior advisor. She's in our certified senior advisor leadership group. Um, she's just becoming an integral part of our senior economy service landscape here, especially in the Bay Area. Um, So I'm really happy that she's here and she's going to talk to us today about patient advocacy, which is, in my view, a really important and valuable thing for us to have knowledge about when we work with senior homeowners and the families of senior homeowners. It's just going to separate us as professional seniors real estate specialists and a higher and better service to our clients. All right, I'm going to have you go ahead, Sita, and we can get started. Thank you.
Alrighty. Hold on one second. I just need to share my slides. Actually, before I do that, let me just introduce myself a little bit more. So again, thank you, Julie and Skip, for inviting me to do this. This is very, very exciting. And thank you all for being here today. So, as a lot of you have probably heard from a lot of different seniors that you have worked with, a lot of them want to stay in their home as long as possible. And it's definitely possible, but it's sometimes more difficult. And for those of you who are senior real estate specialists, you're probably working with these individuals the closest when it's time for them to make these major transitions, whether that's them downsizing or relocating or determining if their home is going to fit them for months or years down the road. But what's often a little less visible is how much healthcare complexity influences those decisions behind the scenes. And that is where patient advocates are the ones that kind of help navigate that healthcare side, especially because it can be so confusing, overwhelming, feel rushed. And if you don't come from the healthcare system, it can be very hard to understand it. And I do want you to know that there are multiple different types of patient advocates out there. And I have one slide today where I'll go over it. But the main thing that I'll be doing today is talking about the healthcare related patient advocates, since that's what I do and also what I think most of you are more curious about. So before we dive into that, I just want to talk a little bit more about myself. Julie did mention, so I am a doctor of physical therapy, and I still work as a home health physical therapist. I used to work in hospital settings and then transitioned to home health. And in addition to that, I am a certified senior advisor and a
Yay!
yay CSA, and a senior healthcare navigator and advocate. Now, you'll hear a lot of different terms that are thrown around in this space, and you'll hear things like patient advocate, you'll hear advocate in general, care managers, that type of stuff. And the reason why you hear so many different terms is because that these titles are not actually nationally regulated. So people often choose the title that best reflects their background and the type of work that they actually do, which is what I ended up doing. I chose Senior Healthcare Navigator and Advocate because to me, that, at least in my head, it made more sense of what I want to do and what I do with clients than just saying I'm a patient advocate. Um, so because it's more of this like umbrella term that's not exactly regulated, what matters more than the title itself is the scope of support that a patient advocate can provide to somebody. Now, my work specifically overlaps mostly with patient advocacy, but very, very little care management. And so mostly what I do is help adults and their families understand their medical options, navigate insurance, especially with all of the weird rules that Medicare adds and changes every year, navigate hospital systems, and just make sure clients and their families um, are able to make informed decisions. Now, before I became a patient advocate, well, again, and I'm still a physical therapist, and I actually thought I was going to be a physical therapist for pretty much my entire life until I retired. But a series of different experiences kind of pushed me into this world. And the first one was actually when I was in graduate school, and some close family friends were involved in a tragic plane accident. And because the three of them, it was parents and their son, because all of them were each other's power of attorney, beneficiary, and everything. When all three of them passed away, it made a huge legal mess for their extended family, and they had to go through probate and everything, which is a nightmare. So that experience prompted my family and me to start getting our own documents ready, in case anything happened like that. And then several years later, my stepfather passed away, and after living with Parkinson's disease. And although some of his documents existed, unfortunately, they were outdated and some of them were incomplete. So, really unfortunately, to this day, my mother is still dealing with attorneys, even though he passed away in 2020. And then came Medicare. So when my mom retired and she needed to enroll in Medicare, she was flooded with phone calls, email, text messages, snail mail, sometimes with correct information, sometimes with misleading information. And she nearly enrolled in a plan that didn't actually meet her needs. So that experience pushed me to dive into the world of Medicare, which is a system I was never taught about in graduate school. We're taught, yeah, you're going to see patients who have Medicare, and that's about it. So since then, and quite surprisingly, Medicare education has become a core part of my work. So I've done presentations for senior centers, and I've collaborated with the UC Berkeley Retirement Center. And then just on a personal little side note that I'm very proud of myself is after learning all this stuff, I was helping some family members review their Medicare for this year. And I saved two of them, each over $1,000 for next year. So I was very proud of myself for that. Um, and then, of course, finally, there's the work I do as a physical therapist. So I regularly work with patients who were unfortunately given inaccurate and incomplete information in the hospital about what to expect in skilled nursing, home health, outpatient therapy, what equipment is approved by insurance and what's not improved or approved, sorry. And so, in addition to my duties as a physical therapist, I also end up just doing natural advocacy and education. So, taken together, all of these experiences led me into this work where I became a certified senior advisor, a senior healthcare navigator and advocate, and started my own business to essentially support older adults and their families in a more comprehensive, holistic, and proactive way than I could as a physical therapist. So, now that you know a little bit about me and where I come from, let me share my screen so you can see the slides for today. Okay, are you able to see the slides?
Yeah, we can see
Okay,
them.
perfect, perfect. Okay, I'm gonna see how this works. Okay, day. All right, so I don't know if any of you have ever come across patient advocates before. But most people don't realize patient advocates exist until something goes wrong. So whether that's a hospitalization, a new very complex diagnosis, or just a sudden change in their health. So that's usually when most people find a patient advocate. So my goal today is to make this role visible earlier to you so that you have a clearer idea of what patient advocates do and how they can be helpful. and also what to look for in case you need to refer a client to one of them. All right, perfect. So just to give you an agenda for today, first up, we will talk about why patient advocacy matters. Next, we will go into the role of a patient advocate, the different types of patient advocates, because there are quite a few, who pays for that patient advocate and why that matters, backgrounds and training. A common question I get is what is the difference between a patient advocate and a care manager? So I have a little slide and table that breaks that down. And then from there, I'm going to get very practical and talk about when a referral to a patient advocate would be beneficial. So things like when a patient advocate might be helpful for a client, and then also how to find the right patient advocate for that client if this is what you end up helping somebody with. All right, so first up is why patient advocacy matters. Now, on paper, housing decisions come down to like space, location, lifestyle, budget, that type of stuff. But in reality, especially since we're in the space working with older adults, a lot of the timelines for these housing decisions are driven by health changes. So things like falls, hospitalizations, and then things just concerns about like, hey, can they live in their home as long as possible? Is it just a couple months we're talking about or several years? Um, and the reason why patient advocates are great is because they help explain what's going on the medical side. And when there's nobody there to help with that, that medical uncertainty creates additional urgency and stress. And when people feel rushed, they tend to make decisions that they later regret, and they just wish they spent a little bit more time thinking about thoroughly. So patient advocates exist to bring that clarity to the healthcare side so that when the time comes for housing decisions, they're not under unnecessary pressure or incomplete information. All right, so the role of a patient advocate, if you remember nothing else from today, this slide captures the core of patient advocacy. And a patient advocate doesn't replace doctors, they don't replace nurses, and they definitely do not make medical decisions. Instead, they essentially level the playing field within the healthcare system that can feel very overwhelming and rushed and hard to understand for patients. And so, in practice, that means that patient advocates basically play three key roles. First, they act as a translator. So, they help clients and their families understand diagnoses, understand treatment options, and medical language in plain terms. Doctors are very good at using medical terminology. They're not always the best at turning that into patient-friendly terminology. So that's one thing that patient advocates can do. Second is that they can serve as a guide, so they can help navigate the complex medical and insurance, especially Medicare systems that are always changing every year. And that way people understand their options and they aren't left guessing what comes next or surprised with a new bill or why something is covered and why something is not covered. And then lastly, of course, they are an advocate. They're a protector. They support communication with providers and they help ensure that the client's wishes and their rights are respected, especially when somebody feels rushed, ignored, or pressured, which is pretty much might even be 24/7 when somebody is in the hospital, especially. And I've actually sat in hospital rooms. Doctors will come in and they will explain something very quickly to their patient and then they leave. And then that patient will turn to me and say, I don't know what the heck they just did. I didn't understand that. And so that's where advocacy begins, is making sure that people truly understand what their choices are and then feel empowered to either push back or ask questions. Okay, so now we are going to talk about the different types of patient advocates um, and where they work. And one important thing to note is that the term patient advocate, and I think I said this before, it's more like an umbrella term. So there's no single license or certification that you're required to have in order to say that you're a patient advocate. So people come from different backgrounds and specialize in different things. So these are just some of the type of patient advocates that exist. The one that some of you are probably the most familiar with, possibly, is hospital-based or nursing home advocates. Sometimes they're called like patient relations specialist or something. And these individuals work inside the healthcare facility. And they help with things like communication breakdowns, complaints, discharge concerns. So, for example, like if a family feels that a discharge is unsafe, then this patient advocate might come in to help facilitate the conversation between what the doctor's saying, what the nurse is saying, what the social worker is saying, but also what the family is trying to say as well. Um, and so, even though they can facilitate these conversations, their role is limited to what the facility will allow. And I'll get to that in the next slide. So, oh, never mind. Next up, we have insurance or employer-based advocates. And these are usually offered as a benefit from the employer. They're helpful for understanding like that person's coverage, finding in-network providers, and navigating claims, but their scope is usually limited just to that insurance-related issue. Then we have disease or population-specific advocates that focus on one condition, something like cancer, dementia, Parkinson's, disability, and that type of stuff. And they often provide very deep condition specific knowledge, education, and support, but again, within a very limited clinical scope. And then you have legal or billing focused advocates. And these individuals usually specialize in appeals, billing errors, disability claims, and patient rights. So they're invaluable when finances or legal protections are the main issue, but they typically don't provide clinical guidance. And then lastly, you have independent or private patient advocates, which in all honesty can be any of the above that I just mentioned. The only difference is that they are working for that patient or client or family and can follow that person across multiple settings. So at least in the healthcare world, um, when I say settings, there are multiple settings. So you have hospital, you have skilled nursing, you've got long-term care, you've got home with home health, home with nothing, and then you also have outpatient. So these are just different settings um, that it's helpful to have a patient advocate understand all of those different settings and things like that. And then the last thing I wanted to note is that a lot of patient advocates are working virtually or remotely now. So they can attend appointments by phone or Zoom, they can review records, and they can also help just family members who live far away from their loved ones. So, as you can see, there are a lot of different types of patient advocates out there. Again, I'm only going to focus on more so like the healthcare related patient advocates and not the ones that specialize in insurance or legal issues. So now that you know all the different types of patient advocates, we're going to now talk about who pays them and why that is so important. Oh, yeah. So that fit matters. So I forgot about this part, but because not all patient advocates do the same thing, it's important to figure out which one a potential client is in need of, since there are so many different types. Okay, now we're moving on to who pays. So the reason why it's important to know who pays for that advocate is because that will determine how much independence and limitations and boundaries that patient advocate has. Now, again, the first one that we're going to talk about is hospital and skilled nursing. Now, these individuals are free to patients who are in those facilities because they are hospital or skilled nursing employees, so they can raise concerns and explain plans, but they have to operate within the organizational priorities that that facility has. So they have to um, think about things like length of stay, risk management, and discharge flow. So, although they have the title patient advocate, at the end of the day, because the facility is the one that pays them, they have to do what's best for the facility. Next up, with the insurance and employer-based ones, these are usually free to individuals as well, since they're paid for by their employer benefits. And then with disease or population specific, some of these organizations are actually nonprofits, so they can either be grant funded or salaried. And they are a fantastic free resource that can provide really excellent education and support, not only to the client, but also to anybody who's a caregiver for that client. With legal or billing focused advocates, they can pretty much be anything. They can be salary, contract, private pay, and each of those has their own pros and cons, which we just won't talk about today. And then lastly, you have the independent or private paid advocates who are paid directly by the client or the family and have one responsibility, and that is to that person. And so this independence is really, really important because it allows them to push back against whatever facility or discharge plan or recommendations that are happening. They can ask those harder questions, whereas somebody who works for a facility might not be able to push back so much because they're paid by that facility.
Would any kind of insurance pay for that?
So
For private pay?
yeah, so
Oh.
there are some agencies out there that are trying to become patient advocates that are paid for by the insurance company. The downside is that they are still paid for by the insurance company. So even the insurance company could say no and dictate that. And I think I'll bring this up again later, but I have a very strong personal beef against a lot of, especially Medicare insurance companies, because what is happening in the healthcare world, and I really don't like it, is that a lot of care treatments and options, they're not dictated by doctors anymore. They're not dictated by clinicians. They are dictated by what the insurance will cover. That's just a personal, really aggravating thing to me as a clinician.
So
Um,
what kind of insurance would there be that would cover this?
so I'm not 100% sure. I've only heard there's one agency, I don't remember their name, but they were trying to become partners with health insurance companies to be a patient advocate, but I don't know how successful that has been. And then also what the terms would look like. Because again, so much right now is being determined by what somebody's health insurance will cover. So, like as a home health physical therapist, I have to constantly write notes arguing to the health insurance company who has never met my patient before why I think this person needs a wheelchair or why they need additional therapy or why I am requesting a nurse to come in and visit them. Um, so I honestly don't know how that will work. Um, but I hope it does because I do know that finances are a huge concern for a lot of seniors. And so paying for something out of pocket for a lot of individuals is not feasible. But yeah, does that kind of answer your question?
Yeah, it does, but I'm still trying to figure, is this going to be a medical insurance policy or a disability or long-term care insurance or
Yeah, so I
which
think
kind?
it'll depend on the person's situation.
Hmm.
I know at least right now, it's more so trying to see if there can be patient advocates that work with the insurance company itself. Um, yeah, we just kind
Do
of
you,
have to see where things are going to go.
do you find ombudsmen also can work as patient advocates?
Yes, yes, they
Okay,
definitely can. They can
okay,
facilitate a lot of different conversations. I think it will just depend on how much that ombudsman is willing to push back on certain medical things because sometimes, and not always, ombudsmans can be from a clinical background. So if they don't understand that clinical background, it becomes harder to push back and just understand and review all of the nuances when you go from a hospital to a skilled nursing or a skilled nursing to home with home health and that type of stuff.
okay.
Yeah. Okay. Um, so going back to
Oh,
this, because there are so many individuals and they're paid differently, there is no good or bad model. The key takeaway is just basically that Free advocacy is valuable and it is fantastic, but it does have its limitations. And those limitations can really affect somebody's healthcare decisions, including like their safety and then major life transitions. Okay, so we're going to kind of change gears here and talk about the backgrounds and training of patient advocates. So, unlike nursing and social work and medicine, uh, becoming a patient advocate does not require a license at all. So that means that backgrounds will vary widely. Now, some advocates, like myself, come from clinical backgrounds. I'm unusual in the sense that I come from physical therapy, whereas most patient advocates come from social work or nursing. And it's important that we come from these clinical backgrounds because we understand diagnoses, we understand hospital workflows, rehab criteria, and care transitions because we worked inside that system of the hospital or healthcare in general. Now, there are other patient advocates who come from non-clinical backgrounds, such as like legal advocacy, health policy, medical billing, disability rights, and education. And so all of these different advocates can be incredibly effective with any of the things that they choose to do. It's just important to figure out which type of advocate your client is looking for because they do vary so much. Now, some individuals can choose to become a board certified patient advocate, and this is from the Patient Advocate Certification Board. And it basically just reflects an additional commitment to ethics and education. But I've found that real world experience navigating the healthcare system is usually a bigger differentiator between patient advocates. And that's mostly because, especially if you come from certain backgrounds, like a legal background, social work, or clinical, you already have to have some form of ethic training and continuing education. Like as a physical therapist and any other clinician I know, we are required to have a certain number of units of continuing education every year, and a certain number of those units have to include ethics. So that's just why it's an optional certification. So because of that, that is why, again, matching the patient advocate to the specific client situation is so important. And because of that, sometimes families might work with more than one individual. They might not call themselves a patient advocate, um, but they might work with two different professionals. Okay. Very common question I get is the difference between a patient advocate and a care manager. Now, these roles overlap quite a bit, which is why they're often confused, but their general primary focus is different. So, before we get into the details, I need to remind you of a little nuance. So, neither of these titles is nationally regulated. So, there's no single license certification you have to call yourself a patient advocate or a care manager. It's really up to the person, kind of like me. I chose not to call myself a care manager because I don't see myself as a care manager. Um, Whereas I do see myself more as a patient advocate, and that could be different from person to person. So this table will reflect how the roles most are commonly defined in practice, but they're not rigid rules because again, there's no licensing or governing board. All right, so one of the core roles of a patient advocate is clarifying medical realities. So we help clients and their families understand what's actually happening medically, what recovery might realistically look like, how much support is truly needed now and in the future. And that could include things like helping them understand their diagnosis and treatment options in plain English, not medical terms, ensuring they understand what all of those treatment options are for informed consent, navigating insurance rules and appeals, because I will tell you right now, any clinician, they don't know much about Medicare. Everything I learned about Medicare, I had to learn on my own, not through school. We can address unsafe or rushed discharges and coordinate communication between providers. Now, because of all of this, we can also anticipate health-related housing risks, things like fall risk, caregiver burden, caregiver burnout, and whether a home layout will realistically work for somebody 6 months or years down the road. Now, care managers, on the other hand, focus more on day-to-day coordination and ongoing support once those big healthcare decisions have been made. So their work usually involves arranging caregivers, coordinating home services, managing logistics, and monitoring ongoing care needs. So to kind of give you a better example is, let's say somebody's in the hospital and they're being rushed to be discharged, but they're trying to figure out if they need to go home or if they need to go to a skilled nursing facility because the only person at home is their 85-year-old wife who is 50 pounds lighter than them. So a patient advocate can come in and kind of give that patient and his wife possibly a better idea of what the situation would look like if he came home versus if he went to a skilled nursing facility. Sometimes discharge planners will do this, and sometimes they're very good, but I've unfortunately met a lot of patients in the home health setting who were told that, oh, I was told home health means this. And I was like, yep, nope, home health really doesn't mean that. They unfortunately lied to you so you could get out of the hospital. So that's where patient advocates can come in. And then care managers usually are there once the patient is home. And so they help with hiring other caregivers, scheduling follow-up appointments, arranging transportation, and helping ensure like that person's medications and services are being managed consistently over time. So kind of with that general idea, both roles are there to reduce the overwhelm and support clients and their families, but they solve different problems. Patient advocates tend to come in a little bit earlier when those big healthcare decisions need to be made to help provide a little bit more clarity. And then care managers are usually there for that ongoing hands-on coordination afterwards. So if you're ever unsure which one a potential client needs, that might just be a sign that you just need to ask a little bit more clarifying questions from that potential patient advocate or care manager to see which one, if not both, could be beneficial. Okay, so now we're going to get into the slightly more practical stuff for all of you. And as a quick reminder, this isn't an exhaustive list of when patient advocacy might be helpful, but it does cover the most common healthcare related situations. So the first, as I have probably mentioned, is hospitalizations or pending discharges. Anytime somebody in the hospital is about to be sent home, major decisions have to be made, and it usually has to happen very, very quickly. And that usually means that families don't fully understand their risks and their options. Next is unclear recovery plans or uncertainty about the right care setting. Again, this is related to discharge planning. Families are sometimes told, oh, well, they don't qualify for this, but they qualify for this, so we're just going to send them home. And the family might just say, okay, yeah, let's do with what the insurance is going to cover, but they might not understand what that realistically looks like. And they don't know that they can potentially push back a little bit more. You'll see patient advocates also very helpful for any conflicting or confusing medical information. So sometimes different providers say different things, or families feel like they get partial answers or they're not understanding the healthcare providers. And that's again where patient advocates act more as like a translator to kind of help turn all that medical jargon into something that the everyday person can understand. Next, we have Medicare or insurance confusion. And this is a big one because unfortunately, the way healthcare is going, and I mentioned this before, so much of care is being dictated by insurance companies, what insurance companies are willing to pay for, even though, and I mean, the easiest example might be medications. Like your doctor could recommend this one medication for you, and they really think that you should take it, but your insurance won't cover it. So they're going to tell you, oh, well, you can take this other version, which might not be as great, but we're going to cover it for you. So this is just a very common, it's probably the most common example of insurance companies dictating things and not your doctor. Because again, it comes down to cost. People can't afford to pay too much out of pocket if their insurance isn't going to cover it. All right, the last one is family disagreements or stalled progress. So, if somebody's recovery stalls or family members can't agree on the type of care or what to do, it often just means that some of those family members just don't understand medically what is going to be necessary for that individual. So, with all of these things, if you ever find yourself thinking that something is off and you can't quite name it, it might be a time to just call a patient advocate and see if this is something they could even help with. All right. Um, Now, when it comes time to helping a somebody find a patient advocate, if that is what you are going to do, or you can simply just tell this to your clients, it's important to make sure that you go beyond the question, are you a patient advocate? And that's because, again, the term patient advocate is not regulated. So anybody could call themselves a patient advocate. So you want to probe a little further to figure out if this person is the right fit for you. So first off, you will want to clarify who that person works for. Will they be hired private pay? Do they work for a hospital, an insurance plan, an agency? Because again, how they're paid will determine if they have any limitations or boundaries. Next up, have you worked inside the healthcare system, like rehab or hospital facilities? And that's important because, again, as I said, there are so many different settings within the healthcare system. You have hospitals, long-term care, skilled nursing, home health, outpatient, and all that other stuff. So, depending on where the client is at, you might want to find somebody who specializes in one of them or generally knows all of them. It could vary. Um, and then lastly, just asking something that will help define the scope and limits and the expertise of this patient advocate. So you could just simply ask, like, what do you typically do with clients? And this kind of just helps clarify what this patient advocate understands and how they can help moving forward. So remember, it is about fit. Different advocates are valuable in different situations. So make sure to find a patient advocate that matches what your client needs. All right, so last slide, and this is where everything I've talked about is going to kind of come together. When health changes for a lot of older adults, housing decisions also usually change as well. And that's where advocacy can add value. One of the core roles of advocacy is to clarify medical risk and recovery potential and realistic timelines so that when they make their housing decisions, they're basing it on what is clinically likely, not just what feels urgent or overwhelming in that moment. And that clarity also supports safer transitions after an illness or hospitalization. So, by understanding what recovery will realistically require, advocates can then help align the healthcare needs with housing options, whether that means aging in place, downsizing, relocating, just so that whatever the plan is, it reflects and matches the medical needs and support level of that person, both short term and long term. And then finally, it strengthens collaboration. So my role isn't to replace housing expertise. I know pretty much nothing about housing options other than live at home, independent living, assisted living, there's memory care, there is boarding care, and I know what type of medical care to expect in those. But in terms of contracts, pricing, market dynamics, anything, I have no idea about any of that. My role as a patient advocate is to just clarify the healthcare realities so that when somebody makes their decision with possibly one of you or a housing expert, they can make a safer, calmer, and better informed choice.
Sounds like you need to hook up with an SRES.
Yes, exactly. But yeah, so that's kind of in general just why having the two perspectives come together can really make it easier on clients to make just confident decisions and just have smoother transitions. So that is all I have for today. The last slide is literally just my contact information. So again, thank you, Skip and Julie, for asking me to come and give this presentation. I hope a lot of you found it helpful.
Thank you, Sita. We appreciate it. And
Yeah.
I'd like to actually give my 2 cents worth in for my own story on patient advocacy. I guess most of you know I'm an old dude. I'm 76. My body's breaking down, I got mobility problems, etc. But the heart is the weakest link, and I have AFib. And a few months ago, I went in for an atrial or a ablation, where they go in through the groin up into the heart and do the work. And the doctor told me that it was just going to be an outpatient procedure. Then once I had the surgery done, when I was in the recovery room, they told me that I was going to be staying overnight. And I said, well, no, the doctor said I could go home. Well, they couldn't reach him because he was in another procedure. And long story short, I had to stay overnight, which just made a huge problem with all the planning I had for the transportation to get home, etc. And I realized that I needed to have somebody that would be able to help with that. So I've got a patient advocate now, and she comes with me to appointments and is actually on video conferences too. And she's been quite helpful in doing a lot of this stuff. And it makes it so that in case that kind of a situation comes up again, she can vouch for me and say, "Well, no, the doctor said he could go home," and that would be the end of it. So I just wanted to bring up the point that these things are real life problems that can happen, and the advocates can help you with it. One red flag I wanted to warn you about is when you do have a patient advocate, and you want to get them included, especially in the video calls. You're going to have to go through the HIPAA procedure and make sure that the medical organization will recognize them as a person that can be included in with the information and have all the HIPAA forms taken care of. So,
Avery, you have your hand raised. Go ahead.
Hi, sorry, where's my video? Oh, um, well, thank you so much. This is a super helpful presentation. You mentioned the the thing about discharge planners, right? And then like Skip, like you were saying, they're like, no, do you go home? Do you not go home? And then so the discharge planners have the reputation of trying to push people it feels like back home when they're not ready. And then you also mentioned there's the dynamic with maybe the Medicare Advantage plans. So I'm just kind of curious what your take is on why the hospitals increasingly are pushing and pushing and pushing people to discharge. Is it because they're worried, especially for the seniors, that their Advantage plan isn't going to cover another few
Um,
days? Or
so
why do
it
you
kind
think
of
that is?
varies. So one of them is that hospitals have a ranking system, and there is an organization called JCO. And JCO is responsible for essentially evaluating every single type of medical facility. And this is mostly for hospitals and skilled nursing facilities and home health agencies as well. And JCO will come in and they will look at all the stats like, okay, how long have your patients been admitted to the hospital? What is your average length of stay? And so, depending on these types of things, hospitals will get dinged. Like they'll get like a little, I don't know, the absence of a gold star, basically, which can affect how much reimbursement they receive from healthcare insurance plans. So that's usually why they tend to push so hard for discharges. But I mean, there's also just the fact that there are so many people who need to be admitted to hospitals, and there just aren't enough hospitals. So on one side, it's because they're trying to get somebody else in. On the other side, it's because that length of stay actually matters. But what's also very interesting, and I guess hospitals tend to not care as much because they want to get more people out, is that Oh my God, I just had a brain fart right there. Um, what was I talking about? Length of stay. Oh, hospitals get dinged again if that person is then readmitted back to them within 30 days, I want to say. And it's kind of like on a scale where if they're readmitted to a hospital by X date, they have a bigger ding. If they're readmitted at a further date, their ding isn't as big. So there's just all of these things in the background that nobody knows that hospitals are regulated or not regulated, evaluated for. And length of stay is one of them.
That's very helpful. Thank you.
So I take it there's no professional organization for advocates like CSA would be?
Um, Not where it's required. So again, there is the board certified patient advocacy advocate that you can get, but it's not required to call yourself a patient advocate because there are so many different types. Um, so I mean, at some point it might be, but I think it would then get a little complicated when it comes to who pays for them. Because then again, when it comes to the ethical problem of, well, if you're paid for by a facility or agency or insurance company and you have to meet a certain, I don't want to say quota, but a certain requirement, but ethically you don't believe in that, then it becomes very, very difficult to balance. Well, then which governing rules do you go by? Do you go by what you are ethically bound to do, um, just you personally, or do you have to go based on, well, I'm paid by this company and I kind of have to do what they say? So,
Yeah, along those lines, in any kind of advocacy role, so the who pays who is super important because I mean on the outset there's just a conflict of interest presented like automatically unless the family can get their own private pay advocate. So and that happens a lot in a lot of different situations. It happens in senior placement. So one of the things that's I think is going to evolve, especially more rapidly this next coming year, is the business model of advocacy and the business model of placement, and similar roles when working with families. And private pay, of course, is the highest and best option for a family and for a patient. So I'm trying to think of another word because like not everybody's a patient all the
mhm.
time.
I know I have the same issue because as a physical
Right?
therapist, I call them patients, but
Yeah.
then as a certified senior
They're your
advisor, or
clients. They're our
yeah, they're
clients,
clients. It's like,
We're
well,
just gonna
yeah.
have to call them clients. Barbara, do you have an idea?
I have a question, because I was an advocate for my sister and my mom, and it would have been helpful to have a guidebook of questions
Mhm.
to ask. Is there such a thing? Because I had to navigate it all on my own and figure it out, and oh my gosh, working with Medi-Cal was a nightmare, and I had been advised wrongly to make a joint bank account with my mom and my sister. I mean, my mom and myself. So what happened was there was 4,000 in the account and 2,000 supposed was to be divided. The social worker told me this. 2,000 divided by
So,
mom's name, 2,000 mine. But that's not how Medi-Cal looked at it. They looked at the fact it was a joint account. That 4,000 was her money. That was 2,000 too much. It cost her $16,000 the first month of a resident of long-term care in a skilled nursing facility for a month and a half before I could get mom on Medi-Cal.
so,
And then
so you
yeah.
needed Medicare, Medi-Cal, state uh, advocacy, or at least somebody to explain it.
Yeah.
more,
I
yeah.
would
And
be.
there are advocates and care managers and geriatric care managers. And I think all of this is having to culminate into the services that Sita is talking about. Does that make sense?
But it would be great to have a guidebook for families that maybe don't want to or don't have the means to pay for a
Mhm.
professional advocate and
Yeah.
know how to work with the advocates, the care managers I'm talking about cases where your parent is in either rehab or long-term care in a skilled nursing facility. I mean, my mom was 98. She was doing fine on the physical therapy, but they deemed that she wasn't making enough progress. So the insurance company would not pay for any more physical therapy. And she was doing great. Even the physical therapist said she was doing great, but the insurance refused to pay for any more physical therapy for my mom, which I
Yeah.
think it's horrendous. I think it was horrible. And they just figured, okay, she's 98, she's too old, she's gonna die at some point. Yeah, I think it's so inhuman.
Yeah.
Inhuman.
No, no, I agree. And as I said, that this is one of the annoying realities of where we are in our healthcare system, where insurance companies are determining somebody's care, somebody's treatment, and not a clinician. And it happens to me a lot. I keep getting told I can't keep a patient. So then I have to discharge them. Then they end up back in the hospital. Then I have to readmit them to home health. It's just a vicious circle. And I don't know the solution to that. But in terms of the questions to ask, that is a good idea. I think it's good. It'll be tough because everybody's situation is so different. Um, but I think you're right. Just to have like a sheet of paper of just generic questions that could be applied to multiple situations would
And
probably be a good idea.
I suppose ChatGPT could
Yeah.
help me in that
Yeah,
respect.
exactly.
But another thing I noticed was, oh, I lost my thought. Give me a sec.
Well, here, we'll go to Micklin and then we'll come back to you, Barbara.
Okay.
Go ahead,
Hey,
Micklin.
well, yeah, she brought up something that I wanted to ask about anyway, because I have a friend client had the same situation. She was progressing with her physical therapy and she didn't need it any longer. She's still in the facility, but if she wanted to keep the physical therapy, it had to come out of her pocket. So she's still in the facility, and they said she was strong enough, they're working on the upper body, that she could continue the exercise. And a lot of people, even if they're not aged or anything, they need motivation. So sometimes I would go in there and do the exercise with her to motivate her, but I couldn't do it every day. So she had to be willing enough to do it. But if they can pay for it, I can sort of see it on the Medicare side, that if they have progressed to a certain point and if they have the capacity to pay, why don't they?
Long story short, Medicare doesn't want to keep paying for things. But
No, no,
so
I'm saying the private pay. Let them become private pay so they can continue their treatment on their own dime. That's what I'm saying.
yeah, yes, yeah. No, I mean, and I don't know why that wasn't offered. Um, yeah,
Well,
other
And
than
another thing,
Oh, go
I
ahead.
wanted to
Go
get your
ahead.
your phone number because I have other questions too. Because I don't know if I missed it at the beginning. Are you a train? Are you a CSA?
yes, I am a
But your
CSA,
initial training was as a therapist,
physical
and you
therapist. Yeah,
okay,
yeah.
and you
So
switched
I
over.
still am a physical therapist, and I work as a home health physical therapist. So I go to people's homes who Medicare deems homebound, and I work with them in their homes.
Okay, because I did have another. This was another client too. She was released from assisted living, or was it? I can't remember. She was in the hospital first. She wanted to stay in the hospital. She progressed to the point they didn't want to keep her. Went
Mhm.
to skilled nursing,
Yeah.
and then she didn't want to pay. They wanted to keep her there, but she didn't want to pay the 55 a month. She wanted to
Mm.
pay only up to 3,000. They couldn't keep her, so they released her. even though she wasn't physically able to go
Hmm.
home. And I guess she talked her doctor into signing the papers or whatever. So she was released. And I just texted her while you were on because I had some questions from her if I could ask
Hmm.
you. And she said her mom's still the same. She can't walk very well. She gets
Hmm.
limited care in home,
Yeah.
and she doesn't want to sell her property to pay for a better lifestyle, a better care in any of that. And it's really sad because
Hmm.
she's going to continue to decline because she will not pay for what she needs to get better, and she has the money to do so.
Yeah.
See, this is a great example of why we have to plan ahead. You
Yes,
don't want to be doing emergency life planning. You want to do it, when there's no threat of any kind of a problem.
exactly.
If you think about it, there are ways to pay for this. You could use a long-term care insurance policy. You might be able to use a, a medical savings account,
Okay.
and there's other ways that can be done if the planning is done ahead of time. But so many people and families just they ignore it. They say, "Well, it's not going to happen to me," and then of course when it does happen, it's like, "Oh, now what do I do?"
Right. But when you say that, Skip, you're not saying for the elderly person to get long-term care. They're too old. You're talking about
That's
take an
right.
example
They
from
have to
me
do it.
for their
They have
kid.
they have to do it when they can get it, is what I'm saying.
Hmm.
Planning
Right.
ahead.
Right. Right. I got you. I got you. Can I get your number, Sita, in the
Yeah, I'll
chat?
put it in the chat. Um, Actually, let me just stop sharing this first.
You know what? When I looked at your picture, I stepped away for a minute and I saw that thing coming out of your head. I thought it was a crown. And I said, well, you're an angel.
She is an angel.
Maybe she's a,
We think we'll keep her. Hi,
maybe she's
Yeah.
Sherry.
maybe she's
Nice.
Now
a
I can
unicorn.
see you.
I
Well,
actually referred somebody to a CSA for the same client I'm talking about, and she couldn't take her on because she would not pay her. And she's a CSA. And the only way, let me put it this way, if she would refer her, if she would allow her to be referred to an assisted living place to care for her for the rest of her life, then she would get paid. But she wouldn't do that, so she had to release her. That was too
So
bad too.
Theta was in private pay. So in your practice, and if you're going to do an estimate and a quote for a family,
Hmm.
um, what kind do you do an hourly rate? Do you do a
So
retainer?
it honestly depends on what they need. Like, I mean, just the other day, I mean, I also just do phone calls for free if that's all they need. It's just a quick phone call,
Hmm.
because they're not sure what to do. I think Gigi, who was at the last.
Complimentary consultation.
Yeah, yeah. Well, so I mean, she had called me. She's like, I don't know what to do. I don't know what to tell the family. And I was like, just have them call me. And so we talked,
Yeah.
and I just told them what they could do, what their options were, and if they needed more help, they could call me back. I haven't heard anything, so I'm hoping things went well to the point where they didn't need me. Um, but no, so normally what I do is I do have like a 1 hour consultation just to figure out what type of help they need. And then based on that, it's either hourly if it's going to be more straightforward, they don't really need me that much, or it is a retainer if it's a very, very complex case where I might have to try and talk to different doctors. I do have to get a HIPAA release. I need to be the one that the doctors call or they call somebody's family member who then will call me to put me on the phone at the same time to understand what the doctor is saying. So it just kind of depends on the situation. And I'm pretty flexible.
Hmm.
So
Great.
for as far as rates go, do you quote or do you have like
Um, so at least for the initial consultation is 1 hour, $200, and then based on that, it kind of goes from there. So if we did need like a retainer, then yes, I can usually quote them at that time. And I try and be as honest as I can, but you never know. So things can get better very fast or they can get worse very fast. So just yeah.
yeah, good to know.
So,
That's
but there is a range. It's not like, oh,
yeah.
my retainer fee is absolutely like $5,000 a month, regardless of how much you need. It's like, no, no, no.
Well, because it's highly individualized.
Yeah.
All of us deal with very, very unique situations, and we have to address that every single time.
Yeah.
I had one last question. Where do you get your referrals from? For the
Oh, I get
source?
um it kind of varies. In all honesty, I've gotten some actually since the first CSA event I went to. And then because I've done things with UC Berkeley retirement, I've
Mhm.
gotten several phone calls from people who have attended the various presentations and workshops that I've done with UC Berkeley.
Great. Thank you.
Mhm.
So workshops. So
Yeah.
yeah, workshops.
Workshops?
Yeah. Well, we're going to put that in business
Yeah.
plan
I'll be calling you
2026.
myself for that.
Mm-hmm. Mm-hmm.
Yeah,
Thank
well,
you,
I mean,
Julie.
if there are ways that I can put this out there for that is more affordable, as somebody mentioned earlier, like a handout, like that is what I'm
Mm-hmm.
trying to make this more accessible because I know it is not cheap and healthcare is very, very confusing. Like
Mm-hmm.
I know how confusing it is. I've worked in hospitals, I've worked in home health, I've worked in outpatient, and every single setting has different rules. And it doesn't help that depending on your insurance plan will determine those rules in each of those settings.
Mm-hmm. Avery.
Oh, clicked the wrong button. I lowered my hand without turning the microphone on. Um, uh, I so yeah, so you're a CSA, and I've seen you on the Leaders Network. And then I remember in studying, of course, there's the advice to have, especially people when they hit the age 70, to go towards more like geriatric specialists. But obviously, they're not everywhere and not every hospital system. So I just was curious on like, for someone who's on the ground, do you see that being more available, or are people really having to just kind of really push their primary care providers as they already are and say, did you really think about that from like a geriatric management? So I'm just kind of
Um,
curious what you've seen.
yeah, so unfortunately, there literally are not enough geriatric specialists in the United States. Like that is a fact. For how many older adults and seniors we have in the United States, there are not enough. And it's going to be very interesting these next couple years. I know primary care physicians are absolutely overloaded. The amount of patients they are asked to see is absolutely ridiculous. Um, which then means that they can't really get to know their patients very well. Um, and I'd like to think that there are more people who are willing to go into the gerontology world. Um, I do know that there are more programs out there that are trying to put out like certificates or just continuing education courses. Now, like, I don't even mean just a certificate, but a full-on like you're in a USC program for 3 to 6 months learning about gerontology and geriatrics. But I think it's going to get pretty ugly, especially with the way that Medicare's going and all the cuts and all the new rules that are coming in. Um, I hope it's not going to get ugly, but
Oh, it's going to get ugly.
I'm like
Yeah,
I
it's
like to be optimistic, but with the experience I've had as a clinician since I started working as a clinician, it has gotten worse. And every healthcare provider is being spread more and more thin, which then means less and less care for the actual, in this case, patients we are working for, which then means it has to fall onto that patient or their family to advocate for them and to push for the care or the treatments that they really shouldn't have to push for.
Would you say part of advocacy in what you're creating, endeavoring to do could include options for alternatives such as outside the normal offerings of medical care, smaller clinics,
Mm.
very highly focused practices, functional medicine
Hmm.
practices, um,
Yeah.
all the alternatives, and they are all coming together to
Hmm.
provide new ways in order to get health and treatment.
Yes, yeah, no, and it's funny that you mentioned that because I actually have quite a few friends who went from being nurses and PAs to now practicing functional medicine.
Yeah.
Um, so yes, I do think we are leading that way. The only downside is that they are very expensive. And insurance, for the most part that I know of, doesn't cover them. At least all the ladies that I know, they're private pay and they are not cheap. Like
Not
even,
cheap,
yeah.
but the more it grows, it's just
Hmm.
like with any business endeavor, the more it grows, the more affordable it's going to
Yep.
become.
Yeah. Yeah, so it probably is going to start heading that way. I mean, there's so many problems with our healthcare system in general. And one of those is the fact that we just treat symptoms. We don't treat the cause. And that's part of the change in functional medicine, at least, is like, okay, what is causing everything? Why do you have all these symptoms? Okay, you have high blood pressure. Why do you have high blood pressure? I'm not going to give you a medication to treat your high blood pressure. We're going to figure out what the root cause is, and then hopefully your high blood pressure goes down. Um,
I
so
think this is
yeah.
where we can create advocacy. You create advocacy in the arena that you're in. We do it in the arena that are in, and we all create a collaboration. It's going to be
Yep.
full service to the families, which is
Yeah, no,
super
that's what I'm
important
hoping.
going forward. Yeah, totally. All right,
Um,
we're gonna
oh, sorry. Can we
go
have a
ahead,
little?
Lynn, and then
Oh,
just real quickly, and then I'm gonna do the raffle today. Okay.
okay. So, see, thank you so much. What you do is obviously life-changing and very important. And I just wanted to clarify a few things. So, the first thing is your title. You said CSA because I know that I'm working with a CSA, and what they're doing is tours for my senior clients of different senior facilities, and they get compensated by the senior facility for placement. So, am I correct? Is that another part of your work that you do, or is
That
that
is nope. No.
okay?
So it's actually very funny. The first CSA event I went to, I met so many people in real estate and I was like, why are there so many people in real estate? I wasn't expecting it.
Uh-huh.
But no, that is not part of what I do.
Oh,
I
okay.
leave that to people who are like senior placement specialists. I am
Oh,
not a
okay.
senior placement specialist.
Oh, okay.
I can tell you at like if you have medical questions like okay, how much nursing care can somebody expect in a
Right.
hospital, in a skilled nursing, if they live in a facility, and that type of stuff, that I can answer. But in
Okay.
terms of taking them to places, getting compensated
Got it.
by
Okay, you're on the
the,
healthcare
yep,
end of
yeah,
it and not on
I'm
the
very much
housing.
on the healthcare side of
Okay,
that.
and not on the housing. Okay,
Yeah.
that's clear. Okay, the other question is, I have a 8,000 square foot home which been on the market for a while. It's a unique custom-made home where we were actually approached by transitional housings um, for patients that have outlived their Medicare, I think, coverage in a facility. I don't know. They're like private home healthcare. And I don't
Mhm.
know if you've heard of it because what they told me would be they wanted to buy my listing. They wanted to like rent and buy it because they were going to treat patients and have, like home health care specialists come. And what they were saying is that Medicare covers a couple of months of like physical therapy or whatever care in the hospitals. And then when they discharge, but they're not ready to be discharged, that they come into more of a private home setting. But it's not just them, there's other patients, and then the workers come to that one house. Have you heard of anything like that?
Not exactly. I mean, what you're like,
Sounds
it
like a
almost
board and
sounds
care.
like, oh, sorry, what'd you say?
Sounds to me, it sounds like a board and care,
Yeah,
what
I
she's
was gonna say
describing.
this sounds
Well,
like a board and like
Clint, is that a
almost
single level? Is that a single
No,
level?
board and cares can be any level.
No,
Board,
we have 4 levels. We have
board,
basements, main
Yeah, I
level.
know which one you're talking about.
board and care does not include medical though. So
Yeah.
it's only going to be for custodial care, not medical.
Okay, whatever it is, it's a very hot industry and there's a huge demand because I don't know, are you familiar with the coverage that Medicare gives the
Yeah.
patients? Is it like a couple of months after they
So again, it
mm,
varies depending on which type of Medicare they have. If they have
oh,
original Medicare versus Medicare Advantage, it will change. So
oh,
with
okay.
if you have original Medicare, and again, it also depends on if you have a Medigap plan, because if
Okay.
you don't have a Medigap plan, you will have to pay more out of pocket.
Okay.
So again, this is why it all goes down to what type of insurance they have,
Right.
which is then how I got into so much Medicare education. So
Right.
when somebody is discharged from the hospital, okay, they are also again assuming that they have had 3 days in the hospital. This is one of those weird Medicare rules. Um, but if they
It's
had been,
3 nights.
mhm,
Three
yeah, if they
nights.
have been
3 nights.
admitted to
Okay.
the hospital as an inpatient for 72 hours straight, they
Uh-huh.
cannot have been considered observation or ER and that type of stuff. They can then get transferred to a skilled nursing facility that will pay for a certain number of days. And again,
10
depend.
days.
Hmm?
10 days.
Oh,
Yeah.
10 days.
Yeah,
Okay.
so they'll pay for, so again, it depends on if you have a Medigap plan
Okay.
or not, or an Advantage plan. Because if you have a certain amount, or depending on which plan you have, you either have 10 days, and then you have to start paying a daily copay. Whatever that is, it will be based on your insurance plan. Or if you have Medigap and you have a very certain type of Medigap plan, you can stay there, I think it's up to 100 days, and your
Oh.
Medigap plan will cover that daily copay.
Mm-hmm.
Again,
I
this is
think it's
why,
Medigap because
yeah,
I think they said, now you're saying 100 days. That sounds right. Because I think they said they covered up to 3 months with their Medicare. And
hmm
then later when they're discharged, but they're not ready to be
hmm
discharged, like some of the cases you're talking, they have to go into another private facility.
So
And
what they could be talking about if there is medical care involved, and I mean to the point where there has to physically be a licensed nurse
yes,
on the premises
that's
the
what they
entire
said.
time,
Yes, that's
that
what
they might be looking into your place as a long-term care facility.
yes, that's exactly what it is.
Yeah,
Yeah.
so
Until they're
that's
ready to go
different.
back
Yeah.
home. Yeah. Hmm.
Yeah,
Lynn,
so
Lynn,
Yes.
we covered this in one of our sessions that was on Medicare earlier in the year. So you might go back through the recorded sessions and catch up with that then.
Okay.
So yeah.
Okay. Thank you, Skip.
And folks, I've got to jump off here. I got to go to my own doctor appointment
Oh,
now.
All right,
So
well, we're gonna do the
everybody,
raffle, but not that you're.
everybody have a great holiday, and I'll see you next year.
Okay.
oh,
Goodbye.
is this
Bye,
our last
Skip.
Bye,
one?
Skip.
bye,
Bye-bye.
wizard. Okay,
Uh,
we're gonna do the raffle now.
What's the raffle for?
Oh wait, hold on. I'm gonna do this.
What's the
Do
raffle
this.
for?
Hold on.
Is this our last series for the year?
Yes.
Oh, we love you, Julie. You're amazing. And so, Skip.
Well, we're gonna have there. Now I can see it. Now you can see it. Okay. Everybody's in here. Valerie's gonna come over here and pick pick a name out of the bag.
I
Go,
recall that
guys.
we're not doing 2 days.
Rhodey!
Hey, I was due. I was due.
All right, let me tell you what the prize is.
This is still on my calendar.
Stage, not age.
Oh, right.
Ah, awesome. Now I know what I'm waiting for Christmas.
Do you have this book yet?
I do not.
You can.
I do not.
That's awesome.
I thank you very much.
Sita, this is a great book if you're not aware of it yet.
What's the topic?
Stage, not age.
Oh, it's a senior book, of course.
Well, it's how to understand and serve people over 60, the
Oh,
fastest growing, most dynamic market in the world.
Well, there
Yes.
you go.
Yes, indeed.
Yes.
Right
Not a
on point.
Not a shy statement. In fact, Sarah's, okay. Susan, this next year, we're gonna get Susan Golden is the author for that book. We're gonna
Mm.
get her, we're working to get her to come to our group to do a talk. And hopefully that will happen this next year. Hopefully this next year, I was talking about what to look forward in 2026 because our seniors economy businesses are just going to explode. And we need to be ready for it. And what Sita's doing, what we're doing, what Avery's doing, what Ron's doing, what all of us are doing is just
Mm-hmm.
going to be phenomenal. And it's going to be so needed. And it's obvious too, because just having this talk with Sita today, we identified a lot of the gaps, a lot of the needs, a lot of the missing pieces that occur. And by we have our profession, you have your professions, our skills. We're going to bring all of these skills together as a collaboration to serve seniors, the whole families too, multi-generational, because whatever it is that we work with the seniors on, we need to work with their adult children on, and then the children of the adult children. Hopefully, by the time they get to be the age of the adult children, they will have a better plan
Mm-hmm.
in
Agreed.
place.
Agreed.
And then
Oh,
so they can have higher and better conversations with Sita, with Avery, with Lisa, with Roni, all of us in the operating the business of our lives.
mm-hmm.
So just having said that makes us sound super important, doesn't it?
We got the connections. We got the connections. And speaking of that, Julie, I am doing the next workshop January the 20th. And I will send it to you if you want to send it out
Yes,
to the
please.
entire group. Yes.
That would
And,
be
and what
fabulous.
Skip had said is very, very true, is getting the youngsters, well, they don't consider themselves youngsters, but they're younger than us, but the adult children involved so they
Yeah.
can see it for themselves. In fact, I got my daughter involved. I never thought she'd take this up, but she did because she sees what I do and the stress that I go through. Uh, because I really care about seniors and I really thinking because they've lived so long and they're getting the bum rush from the government, from just the fact that they're older and there's not a respect for senior, especially in the US, as it may be in other cultures. So I'm getting her involved and I'm telling her friends who are around the same age. She just told me one of them at the age, I think she's around 45, 47, had a stroke, high pressure, and some of which she brought on herself. Some of them have died from overdoses. High blood pressure is unbelievable.
Well, that just reminds me of the one of the original stories that I learned from Anna Lee. From Anna Lee was a family from the Invisible Agent. You know, Anna Lee at Care Right. One of her early family clients, the family the father got in a snowmobile accident in
Mm,
Colorado and ended up in the of course in the ICU and all of that. He was like 35. They had
mm,
nothing in place. They had no plans in place.
mm-hmm,
They had nothing in place. And
mm-hmm.
they did engage Annalie and her services to help the family through. But that was a 30s family. It doesn't matter the age group really.
That's right. That's
It's
right.
just being prepared, being prepared.
Exactly. Exactly.
All right, well, now that's going down a deep, dark path. Let's not do that.
It's Christmas.
It's
But
Christmas. We're
but it's the
done. All
time to
right.
plan for next year so they don't go through it. And it's
Right.
taking little tiny steps, one step at a time
Once.
before they get it anyway. Because
Mhm.
usually even the workshops I did this year, I'm repeating next year and adding more. That's why I'd like to talk to Sita and what she does so she can
Yes.
advise it. They don't need to get it from me.
Yeah.
I just want to bring, you can't make the horse drink. You have to bring them to the water and let them soak it in. So that's why I want to bring the appropriate expert in to talk on their subject. And if they need to sell a property, I'm there. But if they want to rent the property, I'm still there. I can refer it over to a property manager. Or if they want to downsize and still buy real estate, I'm there. So it's all about us working together. Speaking of that, from that showcase, I'm still having people asking me about the bus tour for the other facilities.
Oh, okay. Well, that's part
Yeah,
of 2026.
yeah, it is.
Yeah, we're gonna get on that. So Sita, one more thing real quickly. And then this is something that you may not, and you'll be learning because now you're in our CSA group, so you're stuck with us forever. Okay. But us as SRES, the Seniors Real Estate Specialist, is a little bit different than other realtors. Our mission is to preserve, protect, and guide homeowners at any age, to protect their real estate asset and facing life challenges. So it's a little bit, like I said, it's a little bit different, and that's what we do, and that's what makes us different. And a lot of us are CSAs as well. So, Roni, congratulations. Thank you. Again,
Thank you
you are
very
the
much.
raffle winner for today.
Julie, there was something else too. I did go
Uh-huh.
to the web page, and it's for the professional. It's not consumer facing.
You
So
mean
there's
the
nothing.
website for us?
Yes,
Yeah, my website, that's for our group. Yeah.
right. Okay, I sent
Yeah.
you somebody. Then
Yeah,
I
it's
said, oh
not
no,
consumer facing.
right. Okay, we don't have
Yeah.
that yet, or will we?
Well, someday. Do you know how hard it was to get that one up?
I
Oh my
know.
God,
I
seriously.
know.
You
I know.
know, like making people think it's so simple. Just go on GoDaddy. No, it's not that easy.
Yeah.
All
It's
I
a
right.
great
appreciate you
Would,
did it.
website.
can I ask a
Lisa,
question?
go ahead.
Would you recommend a video that can be sent to like the senior living communities about what a CRS is and does, and, or maybe I could send out to
SRES
possible
or,
people. I mean, just clients, possible clients.
oh yeah, you know, that would be a really good project. We should produce that, Lisa.
Yeah, let's do it.
Let's just do that. Let's just because
I
if there was one, I would tell you, and there isn't one. So let's
not even on the NAR site, right? On the
Well,
SRES site.
SRES does
never
have a
mind
site.
NAR car. No,
Yeah,
no,
they do have a
no.
Get
site.
it.
I
We'll
don't
get it
think
right
it's
here.
that great. I don't
There
think it's
there
that
is
No,
some
great.
stuff. Yeah, there is some stuff on our SRES portal, but nothing that's worthy of no,
But we do.
not yet. I mean, they don't have anything like what Lisa was just asking about.
no, I think we need
No.
one. We need
Yeah,
one.
we do one, and we're gonna make one.
And
We'll just go
and
do that.
it wouldn't hurt to put some of these like Sita, like
I know.
she does on there to speak a little
Exactly.
bit, to talk a little bit just about, why
Yes.
they're important and, to
Yeah.
obviously build up us, but
Yeah.
yeah, for some of the resources that we use that
Sita,
come
we're
into
gonna
play.
keep you so busy now. And plus, and we'll see you on Thursday as well. Oh, right, Avery. Okay, one last. You can close us out, Mister.
Okay, well, actually, we talked about the Sizzler reel for senior spaces. And so I was wondering
Yeah.
if you had an update on like when is the pilot
Oh,
going to come
yeah.
out?
Brian hasn't given me the airing date yet. As
Can
soon
you
as he
explain that,
Oh,
what he's talking
so
about?
one of our colleagues, Brian DeVore from San Diego, has done a TV show, much like an HGTV show,
Mm-hmm.
for seniors. Oh, now it just flew right out of my head. Anyway, it's in the bulletin. I put the sizzle reel out on the bulletin, and as soon as Brian gives us the air date, then I'm going to put that in the bulletin. I'll send it out to everybody. And we got more stuff coming, Avery. More TV stuff. That's what I'm saying. I'm just
Awesome.
being,
So exciting.
yeah, I'm kind of being cryptic about it, but 2026 is gonna be the bomb.
Awesome. Yeah, awesome. Dale Corpus does a podcast. It's very
Yeah,
good.
yeah.
Very good.
Yeah, I know. He's fabulous. He's in our group.
Yes.
And So, okay, well, don't get me started on all of that. We could go on all day long. Last week, Sita, we went for 2 full hours last week. It was amazing. And that was an
Oh, man.
impromptu thing.
Yeah, no, sorry, I couldn't make it last time. I literally came home. I was like, well, that did not happen.
No, so that's okay. One reason why we do have the recordings up on the SRESN website, and so everybody can access as archives. All right, everybody. I'm gonna probably put out bulletins, even though we're not having meetups, because it's just the habit that I have now, and I need all this information and all these resources to come to you. And it's where I keep things organized. So, and then everybody have a great Christmas and a happy New Year, and we'll see you guys the first week of January.
Sounds great. Thank
Thank you,
you.
All right,
Julie.
thank you. I love all
Thank
you
you, Sita.
guys.
He's so nice.
Thank you,
Thank
Oh,
you.
Merry
Julie. Happy
okay.
Christmas.
holidays.
Thank you.
Bye bye.